Good evening. Welcome everyone for today's class on amputation. I formally welcome Dr. Shravan for and also thank him for agreeing to co-host and moderate the today's session. Amputation is one of the important topics for a general surgeon, and I will ask Praveen to start off the class. Thank you, Praveen. And
Yes,
I
sir.
request Shravan sir to intervene any time and also ask questions and also suggest anything, any modifications or his techniques or whatever he has to tell in
Sure,
between
sir.
any time. Thank you.
Sure, sir.
Thank you.
Thank you for the invite.
Praveen, start
Yes,
off.
sir. Yes, sir. Good evening to everyone. Today's topic of discussion is amputation. So we'll be seeing the introduction to amputation, indications of amputation, types, principles of amputations, its complications, and processes. Amputate is a Latin word which means to cut off or cut away. The definition of amputation is removal of limb, part or total from the body, while disarticulation is part removed through a joint. And this incidence is more common in 50 to 70 years, and its male preponderance with 75% and more in lower limbs of 85%. Due to lack of analgesics and narcotics, in the olden days, there used to be the classical circular cut. That is, the detachment of skin, muscles, bone will be at the same level. Then Petit in 1718 had developed the two-stage circular cut in which skin will be transected first, followed by muscles and bones more proximally. Then Broomfield in 1773 had developed the three-stage circular cut in which skin will be cut first, muscles more proximally, and bone most proximally. Then Langenbach in 1810 had developed this flap amputation in which he used a soft tissue flap with the, to cover the stump without tension. And one of the famous surgeons in amputation is Robert Liston. He's a Scottish surgeon, and he was able to perform limb amputation in 28 seconds itself. And one another famous case is he amputated the leg in 2.5 minutes, but in enthusiasm along with patient's testicles. Coming to indication of amputation, it might be due to dead limb, or dead loss limb. Dead limb, the absolute indication is irreversible ischemia in a deceased or traumatized limb. Relative indication is peripheral vascular disease, burns, frostbite. And coming to dangerous indications, which includes the malignant tumors, gas gangrene, crush injury, and dam nuisance. That is, a retaining limb will be more worse than no limb at all. And this includes gross malformations due to congenital anomaly, chronic infections in which infection does not respond to antibiotics and wound debridement, and severe loss of functions in case of recurrent pathological fractures where stabilization is impossible. And other indication is trauma, in which we'll be using the mangled extremity score. And based on the score, if the score is greater than 6, then the requirement of amputation is. And coming to relative causes, in developed country, most common cause of lower limb amputation is PVD, while in developing countries, it's trauma followed by a disease. In upper limb amputation, the most common cause is trauma and disease in developed countries. In developing countries, it's mostly due to trauma. And coming to types of amputations, it is divided into minor, major. In minor, it is of toe and partial foot amputations. In major, where most of the limb is removed. Other type is closed versus open. In closed amputation, these are all elective procedures in which skin is closed primarily. Open or guillotine amputation is done usually in emergency procedures. The skin won't be closed over the stem. The skin closure is later done as a secondary closure, or a plastic repair in which soft tissues are repaired without cutting the bone and skin flaps are closed, or by revision of stump where terminal granulation tissue, scar tissue, and moderate amount of bone will be removed and stump reconstruction is done. In reamputation, amputation is done at a higher level. And these are the various amputations which have old terminology and newer terminology. The newer ones are for below elbow, it is now transradial. Above elbow, it is transhumeral. For Symes, it is ankle disarticulation. For below knee, it is transtibial, above knee, transfemoral, and hemipelvic transpelvic. And these are the various levels of amputation. The most common
Explain, Praveen, explain the common ones.
yes, sir, in the next slides, we'll be talking all about these
Okay, okay,
amputations.
okay, okay.
The most common amputation, both in developed and developing, is in the lower limb is below knee amputation, that is transtibial, followed by above knee, that is transfemoral. In the upper limb, it is below elbow amputation, that is transradial, and above elbow amputation, that is transhumeral. Coming to principles of amputations, deciding the amputation level usually depends on the disease, extent of the disease, and the trauma. Usually, more the distal level, functionality will be better, but it will be associated with more complications. More proximal level, the functionality is poor, but it is associated with less complications. Uh, Usually, tourniquet is advised for all cases except in severe ischemic limb, and the pressure which is required is usually in upper limb it should be of 50 to 100 mm of mercury above the systolic pressure, and in lower limb it should be of 100 to 150 mm of Hg above the systolic pressure. So on an average, upper limb while doing the tourniquet pressure should be of 250, and lower limb it's around average of 300 meters of mercury. So coming to skin and muscle flaps,
I mean,
skin
what is
should
the
be of
time for which you can use tourniquet? Like a cutoff time? Can you use it for hours together on that pressure?
no, ma'am, intermittent pressure, ma'am.
Okay.
No, Praveen, what do you mean by intermittent pressure?
So around 45 minutes to 1 hour, it will be relaxed and then the pressure will be applied, sir.
I didn't get you.
So, it's not like whole time pressure will be applied. Intermediate pressure will be decreased and then it will be reapplied, sir.
When will you decrease it? Or when will you decrease the pressure after what time? That is what Sanya is asking.
Sir, it's around 45 minutes, it is.
Shravan sir, your input, sir.
So the 60 minutes is what we keep, sir. Once you fit 60 minutes, deflate and reinflate again. Deflate
For
and leave it for at least 3 to 5 minutes.
okay.
Allow perfusion and then, if required, reinflate.
Yeah. So any other inputs or questions you want to ask, sir, here, or you let him continue?
Let them continue, sir.
Yeah. Okay, I hope it clarifies all the questions, I think. Okay, continue, Praveen.
Yes, sir. The skin flaps should be of full thickness and should be mobile. And the muscles is sectioned usually 5 centimeters from the point where internal bone dissection is decided. And the muscle suture can be done by myodesis or myoplasty. In myodesis, muscle will be sutured to the end of stem. Myoplasty, opposite group of muscles will be sutured. Preferred one is myodesis, as there will be of uh, maximum strength and less atrophy. And coming to blood vessels, it should be isolated, doubly ligated with non-observable sutures and then dissected. Coming to nerves, nerves should be isolated, gently pulled out at least 2 centimeters, and it should be sharply divided so that the end retracts well proximal to the level of bone section. And there shouldn't be crushing of nerves. If it is there, then patient may develop post-op pain.
What are the vessels and nerves and what are the surgical anatomy?
Sir?
What are the vessels and nerves you get and what is the surgical anatomy of that?
Sir, he will be talking
Sir,
about
here
individual
telling
amputations.
this is common principles.
Okay.
Common principles. Okay. Continue, Praveen. Continue.
Yes, sir. Yes, sir.
So nerve, do you cut with blade, scissor, or cautery?
Blade, sir.
Why?
A sharp blade is required, sir.
Why you can use cautery, no?
Nerve
What
damage will be
happens
there,
when you
sir.
cut with cautery?
There will be damage to the nerve, sir. Crushing
Anyway,
of nerves.
leg is going, no?
But when it is retracted back, there will be post-operative pain, sir.
Yeah, post-operative pain because
Due to that crushing of
neuroma formation is very high if you cut with cautery.
yes, sir.
Okay.
Yes,
So
sir.
even though when you cut with blade, you still get a bleeding from the nerve. Doesn't matter, it will automatically settle down. The reflex would be to immediately catch that nerve and again buzz it, but never do that. Carry on.
Okay, sir.
Continue, Praveen.
And yes, sir. And excessive periosteal stripping should not be done because it leads to sequestration. And the bones should be trimmed. Bone end should be trimmed at the level of stem. Then post-operatively, you can use soft dressing or rigid dressing. Rigid dressing is preferred because it reduces the edema and also it reduces the pain, which causes improved healing, early step maturation, and patient have the chance of early ambulation. So the same principles. So the ideal stem should be of optimum length. It should be of smooth and rounded. It should be firm. Muscles are sutured such that it should be converted into fibrous tissue and serve as an effective cushion. Vascularity of flap should be normal. No projecting spur of bone. Stem shouldn't be under tension. And in upper limb, the scar can be terminal, but in the lower limb, posterior scar is desirable to avoid pressure. And the optimal length of residual bone in the lower limb, in the above knee amputation, it's 7.5 to 10 centimeters proximal to superior border of patella. In the below knee, tibia should be of 12 to 17 centimeters. Fibula should be of 1 to 2 centimeters shorter than tibia for a good stump. In upper limb, above elbow amputation, 13 to 20 centimeters from tip of acromion. And below elbow, it should be of 8 to 7 centimeters, 8 to 17 centimeters from tip of acromion.
If the examiner asks, tell me one number, what would be the number which you would tell? Let's say for below knee, if he says, how much centimeter? Give me one number, not a range.
For below knee, sir,
Yeah, for below knee,
15 centimeters, sir.
no. 12 is the number you have to tell for below knee.
12.
10 is the number you have to tell for above knee.
Okay,
Is
sir.
this still the same, no, sir, Niranjan, sir, in exams?
Yes, sir. Same, sir.
Yeah. So 10 for above knee, 12 for below knee.
Okay, sir.
Yeah. Carry
Coming to elbow amputations. Here you can see the various levels of skin markings along with the amputation intended osteotomy sites. This is high. First will be raising the skin flap by incising at the marked skin level. Osteotomies are performed. This is the below above elbow amputation, and this is a below elbow amputation B picture. After bone dissection, muscle groups are positioned tightly and transected at bone ends. Superficial fascia and skin are closed and suction trains are placed.
Praveen, you have to talk about what are the types of incisions you are putting there. Because for each amputation, there is a different incision, no?
Uh,
Shravan
These
sir,
are the
am I right?
Yes, sir, definitely. The type of incision matters a lot. Hello.
Praveen.
yes, sir.
Yeah, yes, sir.
Sir,
Yes, sir.
uh,
Dr. Praveen, what sir
Yes,
is meaning is what is the type of incision for above elbow? What is the type of incision for below elbow? Or is there any variations available? Which is the most commonly used incision? Like that.
Yeah.
the elbow, I did not check the incisions, sir.
No, you only have like shown there. No, there are variation incisions where what they've marked there.
Yes, sir. But name, I did not.
Shravan sir, your input, sir.
Sir,
Which
this
is the preferred?
above elbow is always a fish mouth.
Ah,
Below elbow, you have two options. Similar to below knee, you can create a flap. But
yeah,
flap is difficult in a thin individual. So thin individual is
correct.
acceptable to do a fish mouth.
Fish mouth. And in lower limbs, it is above knee is fish mouth and below knee is flap.
Flap, yes, sir.
Argus flaps.
Sir, is it
Posterior.
depends on vascularity also, sir? Whether what type of incision we are giving?
Vascularity, the
I
question
don't
is
think so.
entirely different for vascularity. The only variation in a below knee is you have something as a skew flap. Skew flap, you do it only when you don't have a adequate length to create a posterior flap.
Okay, sir.
Vascularity for both, whether it's a skew flap or a posterior flap, vascularity has to be good.
Okay, Praveen, continue. Continue. Why are you
Yes,
jumping?
sir. This is the above knee amputation. The patient operator extremity should be in flexion and abduction position as shown in this picture. And here, the skin flaps are marked along with the indented ostomy dissection. Here, the extent of flaps will be depend mostly on the extent of soft tissue tumor or any previous of radiation or any previous operated scar. Muscles, the incision is depend along the skin, superficial fascia, subcutaneous tissue.
No, Praveen, indications for above knee, indications for below knee, all those things you have to tell, no?
Yes, sir.
The same everywhere it is skin subcutaneous tissue and then you cut the vessels and bone muscle cover and all that. That is all the same. So to tell us about the indications.
So, higher abdomen amputations are generally used for primary bone sarcomas, sir. And low abdomen amputations are used for bone sarcomas, which is involving the popliteal fossa or arterial trifurcation area, sir.
No, for us, what is the commonest indication? That sarcomas is okay. In our day-to-day practice for a general surgeon, what is the commonest indication? It's either a
Thrombosis
diabetic
at the
foot
lamina.
infection, it's
Yes, sir.
either a diabetic foot infection extensive or it is PVD, where there
Yes,
is,
sir.
yeah. So those indications you have to tell.
Okay, sir.
When will you choose below knee? When will you choose above knee? So, sir, am I right or any other? Hello? Hello? Praveen?
Sir, yes, sir.
Am I audible?
Yes, sir. Audible.
Yeah, yeah. Shravan, sir, your input, sir?
I just lost you there for a minute, actually.
No, no. What I was asking him was,
Yes, sir.
what is the indication for this thing? Like above knee. When
Yes,
will
sir.
you choose above knee? When will you choose below knee? That is how you decide. And the sarcomas are rare.
Yes, for
Where
now. So for us as a general surgeon, the most common time, first thing is the diabetic foot. Hello.
Yes, sir.
Yeah, and the second thing is trauma. So these, as a general surgeon, you'll be seeing this more. And of course, when vascular point of view comes, it depends on what level the occlusion is. Hello?
Yes, sir.
sir,
Yes, sir. Please, sir.
Yeah, yeah. And Dr. Praveen, how do you decide whether this patient requires ammonia or below knee? Because Dr. Samir was asking about the vascularity, right? How do you decide this patient will heal with abony or this patient, specific patient will heal with a below knee? How do you decide that? You can have a diabetic foot which is extending only up to ankle region, or a diabetic foot extending even up to knee level, correct? But how do you
Yes, sir.
decide which is going to heal?
Based on arterial supply, sir.
Well, that's what
Doppler.
which arterial supply?
Anybody else also can answer, not only Praveen. Nikita.
What's the most easiest and the most cheapest method to find out whether vascularity is good or not?
Doppler, sir. Doppler ultrasound.
No, your clinical examination.
Peripheral pulses.
Peripheral
Yes.
pulses.
So if you have a pulse above, that stump will heal. That's the simplest way. So before a below knee, you should have a palpable popliteal pulse.
Popliteal.
For above knee,
Yes,
you should have a palpable femoral pulse. Very simple.
Okay, sir.
Sir, does the length matter, sir? If it is if the gangrene is almost less than 10 centimeters from the tibial tuberosity, something.
Then naturally you don't have adequate soft tissue cover. You have to go one
So
level above.
that is the principle, no? So one joint above,
Hmm.
Yes.
wherever the infection is or wherever the gangrene is.
Yes.
So
Okay.
indication, you should not tell all this sarcomas and all this is all for all that.
You will fail in exam, Praveen, if you tell sarcoma indication for a bony. Because, yeah, it is true. But most commonly for a general surgeon or even a vascular surgeon, the indications for amputations are totally different from the sarcomas.
Yes.
Sarcomas is for malignancies, but how often you treat sarcomas? It is a totally different entity.
Yes, sir.
And even in sarcomas, now it is limb preservation.
Yes.
Okay, move on.
It can be of a longer stem, medial or shorter stem. In longer stem, it will give best liver. It has good energy efficient and can it have good processes. In
This is
medial
what?
length stem,
Longer stump and medium
sir,
length stump for what?
above elbow amputation, above knee amputation. I'm continuing, sir.
Okay. Go on.
In medial stem, there will be reduced strength of adductors, so there will be increased flexion abduction, and there will be of increased energy expenditure. In shorter stump, there will be weak adductor muscles causing severe imbalance, and usually the stump will lead into flexion and abduction. So patient may require massive expenditure and processes will be heavy and won't be unsuitable for the patient.
What did you mean by lever? The first line was lever, right? What did you mean by that? For long stop, you
Sir.
written best lever, no?
Yes, sir. Sir, the movements of processes will be good, sir.
Movement of process is another thing.
Balancing.
Body balancing, actually, not
sir.
prosthetic balancing,
Yes, sir.
more of body
balancing.
So if he has to bring up the trunk, so if you have a longer stump, it helps to give a counter action like a pulley.
Yes, sir.
So if you have a very shorter stump, the strength of the stump is not enough to bring up the entire trunk.
Yes, sir.
Yeah, go ahead.
The below knee amputation will be using the Burgess long posterior flap and same principles.
So this incision is wrong, no? Like usually you don't put the fish mouth. This
Yes,
is
sir.
fish mouth incision.
Yes, sir. Yes. So,
Explain, you're just moving
Sir,
around.
The same principles will be using, sir. So that's why.
No, correct.
No,
What are the muscles?
what sir is asking is what muscles are you looking at? What muscles are you opposing?
When
That
you,
is what sir
what
is
are the
asking.
vessels which you will be ligating, transecting, where you will be doing that?
Yes, sir.
What are the important vessels? Where will they come?
In the below-knee amputation, will be ligating the anterior tibial and posterior tibial, and these are the vessels.
Is there one more?
Sir, usually
Praveen,
these two only, sir.
Okay, how does the popliteal artery divide? Natural anatomy. How does the popliteal artery divide?
anyone can answer. And as Samir, both of you have been quite.
Yes, sir. Anterior and posterior tibial arteries.
See the
Along with it,
popliteal artery.
peroneal arteries.
Yeah,
from the
so
posterior.
the popliteal artery divides into anterior tibial artery and tibio-peroneal trunk.
Yes, sir.
Okay, the tibio-peroneal trunk, as the name says, has a tibial component and a peroneal component. So the tibial-peroneal trunk divides into peroneal artery and posterior tibial artery.
Posterior tibial artery. Yes, sir.
Okay, so you are ligating three vessels there. Below knee is three vessels: anterior tibial, posterior tibial, and peroneal.
Peroneal.
Above knee is only one vessel, which is femoral.
Femoral. Yes, sir.
Okay.
Yes, sir.
So for below knee amputation, which vessel is most important for healing among the three?
Anterior tibial, sir.
Which has the most bulkiest compartment in the below knee part, in the leg part?
Posterior
Use
tibial.
common sense, no?
Posterior tibial.
Yeah.
Tibial.
Yeah. So posterior tibial is ideal. If you don't have a posterior tibial, sometimes, especially in a vascular patient, you'll have a hypertrophied compensated peroneal. So number one is posterior tibial, second is peroneal, third only is antitibial. Okay, where do you cut the tibia? Where do you cut the fibula? It's the same picture which you showed, no? Which you're showing
Yes, sir.
right now. How do you
Yes, sir.
decide the level of bone cutting?
Sir,
And what are the methods
tibia,
of cutting the bone?
tibia usually 12 centimeters, yes, sir. And
Yeah,
fibula,
that is your skin incision.
skin incision, yes, sir.
Yeah. So from skin incision, your bone level is how much of the
5
tibia,
cm.
and from the tibia, how much is your fibula? And why is that difference? Why can't you do it in the same level?
So, skin to bone should be at least of 5 centimeters difference, sir. And between tibia and fibula, 2 centimeters difference, sir.
Yeah, 3 to 5 is okay, and 2 centimeters fine. Why you have to do that 2 centimeter little higher fibula?
So, for the stumps, sir.
Yeah, stump
This should-
closure is one thing. Other thing?
Weight bearing, sir.
it will be
Sorry?
The process is weight bearing, sir.
Weight bearing.
No, where does below knee processes bear weight? Is it on the stump itself or somewhere else? The weight bearing of a below knee processes is on the tibial tuberosity, not on the cut end of the tibia. So the reason we cut the fibula a little higher is if you keep it equal or slightly longer, then the stump end, the bone may cause a wound in the stump, pressure wound.
Pressure wound.
Okay.
Yeah.
Yeah, go ahead, Dr. Praveen.
the foot amputations, which the commonly done is the toe amputation.
Praveen,
which is-
complications.
Yes, the
Complications.
next it is, yes, sir.
Next year. Okay.
The toe amputation is most commonly done, in which will be amputating the phalanx, and the next common is reamputation. Along with two, part of metatarsal bone will be removed.
Which one is most
others-
common, Praveen? Only disarticulation or reamputation? Which one is most common and which one is ideal? Whenever you're trying to disarticulate, you do
Sir,
reamputation or you do disarticulation?
reamputation is ideal one, sir.
Why?
Sir, because it is avascular bone will be there, which causes non-wound healing and infection.
Non-wound healing because of not because of avascular bone only because of the
Protrusion.
yeah, the head will be protruding into the wound and will not allow
Yes,
it to close, and
yes,
also
sir.
it will be a pressure point.
Yes, sir.
Sean sir, am I right? Hello, Sean sir.
Sir, sorry.
Am I right? That,
Okay, correct.
did you? No, no. Reamputation. Which
Yes,
is
sir.
preferred? Reamputation or disarticulation was the question. He said
Reamputation, sir.
reamputation.
Definitely.
He said
Yes.
reamputation. He said
Hmm.
only it is because of avascular bone, which will not make the wound to heal.
Yes,
So
sir.
there was a reason given by him. I said that is not the only point. It is the bone will be projecting out, and also it will be a point of pressure ulcer because of the
Absolutely true.
head of the vessel.
Uh,
Any other points? I just was asking.
no,
Any
sir.
anything
That's the
else?
main one, sir.
Yeah,
That's the main one, sir.
yeah, yeah. So I will continue.
Yes, sir. And others are transmetatarsal, which is amputating across the metatarsal, and Lisfrancs will be doing amputation at tarsometatarsal level, and Chopots, in which will remove the forefoot and midfoot, leaving the talus and calcaneus, and Pirogov amputation, in which will remove the forefoot talus and will be doing the calcaneo-tibio orthodesis. And, this is the one which provides weight-bearing stumps. The difference between Pirogov and Symes is in Pirogov will be calcaneum will be preserved. In Symes will be completely remove the calcaneum muscle.
When will you do this? Do you really do this?
No, sir. No, it's not done. Previously, it was used to be done. Sir.
Why was it given up?
So, sir, because due to lots of complications, sir. There is
What complication?
improper weight bearing, non-wound healing, stump infections.
Yeah, most commonly it is because of the pressure ulcers which you used to develop in that, and also non-healing of the wound
Yes, sir.
because of the weight bearing directly onto the bone there. Yeah.
Yes, sir. And other special amputations which were rarely done are gritty stocks amputation, in which amputation will be done through leg will be done through knee, and here patella will be forming as a base of the stump. Rehabilitation of the patient is divided into preoperative period and postoperative period. In preoperative period, we'll be taking care of preoperative care assessment in terms of physical, social, psychological, training of the patient, and reassurance. In physical, we'll be assessing the affected and unaffected limb, muscle strength, joint mobility of the limbs, respiratory function of the patient, balance in sitting and standing position. The social assessment will be having friends and family support, living accommodation, and accessibility of the patient to stairs, ramps, or rails. Psychological approach of the patient and his motivation will be assessed. Post-operatively will be that is divided into pre-prosthetic and post-prosthetic. In pre-prosthetic, we'll be looking taking care to prevent postoperative complications, to prevent deformity, to control stump edema, and to maintain general mobility, to re-educate about walking, to improve balance and transfer of the patient. These are all done by stump bandage, and this is the method of stump bandage. For the below-knee amputation, here it is above-knee amputation. And stump management by friction massage, desensitization by pressure, tapping at the stump, and strengthening of the muscles by exercises shown in this. And these are various positions on the exercise which will be advised in the pre-prosthetic stage.
No, you should explain
Sir.
what kind of exercise and why you are doing that actually. Anyway, that's okay. Carry on.
No, it's important, Praveen. Just to mention, it's not enough. You have written there. You have to tell us why you have to do this exercise, which exercise is preferable, and what is the purpose of all these exercises.
Sir, it improves the mobility, sir, and it reduces the stump edema and
No, it will also to
yes, sir.
strengthen
Yes, sir,
the
strengthen the muscles. Yes, sir.
yeah. So what group of muscles where you based on like you have put so many diagrams, no? You should be
Yes, sir.
telling us all that. That is what is your this thing. You should be teaching us all this. You have written there.
Yes, sir. Sir, all done for below knee amputation patients, sir.
Ah, okay, move on. You have to tell us
Okay, sir.
later.
Yes, sir. And this is pneumatic post amputation mobility aid (PPAM). This is like a partial weight bearing, which can be used in 5 to 7 days post-op. This reduces the limb edema and it prepares the limb for processes. And this reduces hip and knee flexion contractures.
Okay, is it available?
In India, no, sir. In foreign countries, they are using it.
Seven, sir, your opinion on this?
Sir, it is available off late, but cost is too much, sir.
Okay, like
I
it's like you have to hire or buy.
buy, sir. You have to buy
Okay, okay. How
because
much
they
does
still
it
have to
cost?
do that stump molding, all those things they have to do. It's like patient has to pay 2 times for processes.
Yeah. Okay.
So in our
How much
setting,
does it cost approximately?
some 40,000-50,000, sir.
Oh, it's almost the stump. Sorry, processes cost.
It cost.
Yes, sir. Yes, sir. Yeah.
Mhm. Is it
So in
really
our
needed
setting,
or
it's difficult to, but I have not found it greatly useful, sir.
okay?
Just for 7 days.
Just for 7
In
days, you have to spend so much.
Go the previous slide. Sir, the muscles just strengthened with each exercise. You should tell us now.
Yeah, he's not prepared. That's why I asked him to like
Man,
put
give
it
a
as a homework.
WhatsApp for this thing.
Put
yes,
it
sir.
as a homework.
Mm.
Yes, sir. Um, Coming to complications of the stump, it is the most common complication is hematoma. It is commonly due to loosening of the ligature and inadequate wound drainage. This causes delayed wound healing and infection. Uh, the treatment will be of aspiration and pressure bandage. This is a hematoma of the stump. The next common is infection.
No, anything to prevent?
Sir,
Anything you do to prevent?
sir,
What to ask?
we'll be placing drains here initially for
Okay,
40
so
to 72 hours.
when will you place a drain? You place a drain in all patients or when? What is the
Sir,
indication for drains?
usually it is indicated for all patients for 48 to 72 hours to place drains, sir.
Seven, sir, is it true, sir? Is it indicated for all patients?
Sir, I generally prefer to keep for all patients, sir.
Okay. For like above knee and below knee, or
Both,
it
sir.
does it depend on the build of the patient or in all patients, irrespective of like thin
Sir,
or lean patients or obese patients?
irrespective,
Nothing
I
of that
keep
sort.
off, sir.
Okay.
I have a personal preference in that. I keep it at least
Okay.
for I'm happy seeing a 2-day nil drain and then pull it out on second day.
Okay.
Yes, sir.
But what is a like recommendation for all patients? Is it there or only like in select patients?
Thin build not required, sir. And
Okay.
any patient on dual antiplatelet or
It's required.
doubtful
Yeah.
stump healing, like possible infection of the stump, cellulitic stump, like
Okay.
that and all, better to put it, sir.
Yeah. Okay. Okay, Praveen. Continue.
Next common complication is infection. This is due to usually underlying diabetes, and if hematoma gets infected and due to PVD. If there is severe infection, then
Why PVD will cause infection? Why PVD will cause infection?
so due to gangrenous.
No, that is more common in wet gangrene, no diabetic
Yes,
foot
sir.
gangrene rather than dry
Oh.
gangrene.
Wet gangrene, sir.
Yeah, so that is different from PVD, peripheral
Yes, sir.
arterial disease. Most commonly, it causes dry gangrene, not the wet gangrene.
So, due to wet gangrene only, sir. Not due to
Mm.
PVD, sir. Yes. And
Okay.
if infection is severe, then we have to do next level amputation, as shown in this similar chart.
Now, how do you salvage?
Sir.
Even like before infection, just by like you straight away go for next level in amputation, or you can salvage the wound. How can you salvage the wound stump?
Sir, by minimal wound debridement, we'll try, sir.
Okay. What are
If
the other options?
vac dressing, you can try, sir.
Yeah, vacuum dressing. So you can let out open up the sutures, put a vac dressing, and then once it heals, you can probably do a skin grafting or a secondary suturing.
Sir.
Chavan, sir?
Yes, sir. Basically converting a closed flap into a guillotine.
Yeah.
Open it up, drain it, wash it, and like you said, vac plus secondary closure.
So if that doesn't work and if there is recurrent infections, then only you go for the one joint
Reamputation.
above reamputation. Yeah.
Find out the cause
Yes,
for
sir.
recurrent infection.
So most common
Yeah.
cause diabetes, sir.
Why only a diabetes?
No,
Why
no.
should
You
we
have to
do get
do
recurrent?
you have to do cultures also. You have to check
Cultures.
check their nutrition,
Mm.
Yes, sir.
check
Basically,
any
it is a
other.
pure vascularity.
Okay.
Move on.
And next common complication is skin flap necrosis. This indicates that there is insufficient circulation to skin flap. And to avoid this, usually to keep as much as possible subcutaneous tissue along with the skin flap. If there is skin flap necrosis, we have to redesign the flap. After,
Any other
deflecting.
method to avoid a skin flap necrosis?
So should take a thick, good thickness of skin.
Mm.
Oh, good thickness means
Good thickness, okay, and then avoid multiple layers in the closure. See, after you finish your muscular closure, avoid 2-3 layers of subcutaneous and skin closure. Okay,
Okay.
that is one thing. Second thing is closely placed sutures. That will also cause skin edge necrosis. Try to keep it far away and like kind of bulk closure rather than layered closure.
Why tension on the flap mine?
There's a tension free. And next common complication is deformity of joints. This occurs due to improper position of stumping leading to contractures. If there is mild to moderate contractures and appropriate positioning of stump and passive
Deformities of
stretching
joints are all
exercise.
long-term complications, no?
Yes, sir. There is mild to moderate contractures, then proper positioning and passive stretching exercises will relieve it. If there is severe contractures, then may require surgical correction. And other complication is neuroma. This neuroma usually form at the end of the cut neurons. And if this neuroma gets attached to the
What is
stump
neuroma?
due to scar, sir,
What is neuroma?
it's a regenerative part of the nerve, sir, at the content. Sir,
I didn't understand.
What is the definition of neuroma? Sir is asking. It's a what is it? It is a disorganized growth of nerve cells.
nerve cells. Yes,
There
sir.
is an injury, nerve injury. If a cut is clean, generally there will be organized this thing.
Yes, sir.
Yeah.
This can be prevented as earlier said by pulling up the nerve at least 2 centimeters and cutting with a sharp knife and gently handling the nerves.
And to avoid
The
cautery.
nerve, yes, sir, and to avoid cautery. And if this has formed, then we'll be accessing the neuroma at its proximal level. And phantom sensation is it is sensation that as if the amputated part is still present, and it is usually seen immediately in the post-op period. And it can be managed by analgesics, mirror therapy, like virtual reality, stump-blindness, acupuncture, targeted muscle reinnervation, or repetitive transcranial magnetic stimulation. Various methods are available.
What is mirror therapy, man?
Sir,
Mirror therapy?
in the picture I have shown some mirror therapy. We'll be placing a mirror next to his normal limb so that he has that feeling of another limb.
I didn't understand.
Shravan, sir, is it right?
I'm not aware, sir. This mirror therapy I've not heard.
It
Praveen, are you
makes,
sure about it?
yes, sir.
What is its purpose?
Sir, it makes the brain that the other, he has the other limb, sir.
No, that is whatever you have shown in the picture. It is
Yes, sir.
about augmented reality. That is, those are the glasses for that.
No, sir, over the top of it, sir, mirror therapy have shown, sir.
Over the top.
First picture, sir.
Okay. In that, what
Sir,
we couldn't understand. You place the mirror in front of the inside of the limb.
yes, sir, near the normal limb.
Okay.
It
Okay.
the brain perception will be changing,
Okay.
sir.
Okay. Okay.
The person can see the normal limb. Now, why should you keep the mirror for that?
No, sir. The other amputated knee, he won't be feeling it, sir.
To imagine the other amputated limb,
Other,
sir.
Okay.
Imagine the other amputated limb as a normal limb. So the brain will
yes, sir.
pursue like that, and
And
it'll
the pain
avoid
will
the
come
this
down,
one.
sir. Yes,
Okay.
sir.
Okay.
Okay. How effective is it? Like, is there any evidence? I've not heard about it. That's why.
Sir, actually, all this doesn't have complete cure, sir. A partial relief is there, sir.
Okay. Okay. Sir, Shravan sir, your inputs. Which is the
What
most
is
effective, like in your practice?
mainly counseling?
Counsel, sir. Sir told correctly. Counseling, sir.
Okay.
What do you mean by stump liners? Does acupuncture help?
Sir, all in the pain management, sir, by stimulating the nerves.
Where is the pain?
Nerve
Patient
ends.
will have unrealistic experience of the limb.
Yes, sir.
What do
So
you mean by
stump,
stump liners?
so stump liner is specialized sleeve or socks type, sir.
How
It
does it
will,
help?
sir, it will distribute the pressure evenly, sir. At that and that pressure points, the pain will come down, sir.
Is to relieve the pain, is it?
Yes, sir. All these are for limb pains only, sir.
How to correct the phantom limb? This thing
Sir,
management.
sir, this regularly in the time it decreases that pain sensation, sir.
Pain okay, but how do you
Yes, sir.
cure the phantom limb sensation?
Sir, phantom limb sensation, it will in the post-op period gradually it itself comes down, sir.
Okay.
It's mostly in the initial immediate post-op period, sir. So during that time, that pain will be managed by this. Slowly, the therapy will be they'll reduce the therapy sessions, and that sensations will be coming down, sir.
Okay. Where it's common, above the knee or below knee in this phantom limb?
Sir, in both, sir, above and
Both,
below knees, sir.
okay.
Yes, sir.
Continue.
Yes, sir. And in the prosthetic stage, we'll be using the processes. Processes is a replacement or substitution to missing a diseased part. And it contains in the below knee, it is of has socket, pylon, and prosthetic foot. Where there is joints, where there is substitution of joint, there will be of joint in the pylon and socket. And these are the various processes for hip, above knee, below knee, SAMS processes, foot processes, and in the hand for digit processes, wrist processes, below elbow process, above elbow processes. And he's Dr. Pramod Karansethi, who has revolutionized the processes and innovator of Jaipur foot. Initially, we were using the Sach feet, that is solid ankle cushion heel feet. These are solid ankles with no articulation in the foot, and there will be no motions in all the planes. And this should be used along with the shoes only, as there is no shape of toes. But in the Jaipur foot, it provides dorsiflexion to squat, and there is transverse rotation of foot to walk and cross-legged sitting, which is more common in the used in the Indian sitting, and it has more range of inversion eversion. And as there is toe markings, we can barefoot walking is also can be done without the help of shoes. And processes of temporary and permanent type. In temporary, these are used initially for 3 to 6 months post surgery. This helps in shrinking and shaping of residual limb and initial prosthetic training. Permanent is once the residual limb volume is stabilized. So the ideal processes should have functions, cosmetic comfort in functions. It should meet the user's need. It should be simple, easily learned, and dependable. In cosmetics, it should be looking, smells, sounds normal. It should be easily cleaned, stain resistant. Coming to comfort, it should fit well, easy to put on, take off, lightweight, adjustable. And all these are almost met in the Jaipur foot. And poor candidates for prosthetic are lower limb amputee with ischemic limb with an open or poorly healed wound, upper knee amputee with 45 degrees flexion contraction at hip, bilateral upper knee amputee with short hamstrings. So, gait training should be performed in front of full length mirror to observe or correct any fault. They should be increasing the walking time each day and inspect the stump at the end of the day. In young patients, fit amputees, they require 1 week of training. In elderly, around 2 weeks or more training is required. And these are the gait training. Here we'll be teaching the proper residual limb positioning in sitting, standing position, and lying positions, and balancing activities. will giving training to the balance as shown in this picture. Will be making the patient walk along with the process along a rod. And all these are to improve the balance and coordination with the processes. Thank you, sir.
Any questions and doubts from any students?
Sir, this
So,
skin
Dr.
flaps
Praveen, you're
we
telling the Jaipur foot is the best processes.
Sir?
So you're telling Jaipur foot is the best processes, is it?
Sir, it's cheap and yes, sir. Compared to such food, Jaipur is a good option, sir.
Okay, let me correct you.
Until best.
Jaipur foot is the most outdated processes available.
Yeah.
It
People
is
who
a
cannot
cheaper.
afford better ones, they
Yes.
go for it.
All the donated limbs, if you see, those are Jaipur foots. But it is the least favored, most difficult to maintain, and the chances of a patient not ever using the foot again is a Jaipur foot. Okay.
But the mobility wise, it has a good range
No,
of movements.
mobility is
No,
Only
no.
people who
poorest.
cannot afford it, it's
Yes.
just to show that they have got limbs, they use that song.
Mobility is the poorest with Jaipur foot. It's the most outdated foot available.
I
Okay.
think it's a carbon fiber one, no, sir, which is
Yes,
more mobility, the
Yes, sir,
highest
it has to
mobility.
be a pneumatic cuff with a carbon fiber pylon. That is the best. So the previous Belloni amputation stumps, the weight bearing used to be in the tibial tuberosity, but now the pneumatic models have weight distribution along the entire length of the stump. Okay.
Yes, sir.
So
Yes.
that is the most, that is the best type of Belloni amputation stumps you can go for.
Okay, sir.
So that has to be a carbon fiber pylon.
Sir, any other input, sir?
These are all just principles, no? Is another talk on other upper limb amputations, all those things.
No, he has mentioned everything in this class only. He didn't go into detail, that's the only thing.
Dr. Praveen, you
PGs,
didn't
anything?
mention what's your references for creating this PPT? What are
Yeah.
this?
That was a
It's the I forgot to edit the down, sir.
You can tell now.
I'll share it, sir, in the group.
no. You can tell. Sir who is asking from where did you take? Was it a journal? Was it a?
In the PubMed, sir. PubMed and the orthopedics latest guidelines.
Okay.
Any postgraduates? Any questions? Any doubts?
Sir, for the skin flaps, you are using only one layer of suturing, sir, or even not even a subcutaneous?
Single layer.
No. I don't think, sir, never mentioned about subcutaneous. He said multiple layers while closing the subcutaneous tissue.
Muzzle one layer and
Yes.
then enter the next layer only single layer. So skin and subcutaneous.
Yes, correct.
Anything else?
No, sir.
Okay.
Principles of amputation and tumors also I should tell.
Principles of amputation I have mentioned, sir, earlier.
Tumors.
It's sir, the basic principles is same in both, sir. Only in the flap will be not particularly using the standardized length. Based on the tumor margin will be
What you do in
changing the flaps,
osteosarcoma,
sir.
what you do in chondrosarcoma, where do you get commonly, where do you amputate? When will you close the stump after chemotherapy, radiotherapy, all those things?
Adu, we are not included in this
Okay.
class. That will be a different class.
Whether you're presenting or not, that anta. I should do.
Separate, sir.
Present
Separate.
more
That has to be
detail.
separate class.
So the detail is not adequate this time.
Sanya, your comments?
Sir, it was a nice class, but I was expecting more in detail, sir, about all the amputations and how we do it stepwise.
Yeah.
I was expecting that, sir. But otherwise, it was a good class.
Nitya?
It was a nice presentation, but it should have been in more in depth, sir. Like especially the procedure for each and every extremity amputation could have been more elaborate, sir.
Yeah. Shravan sir, your comments are on the class? Praveen's, Dr.
Hello?
Praveen's preparation.
Am I
Yes,
audible,
sir.
sir?
Yeah.
Yeah, it is. I think you should put in a little more effort to make it more detailed, and the steps of each amputation is different. That should have been taken maybe from a atlas, like Zollinger's atlas or something like that,
Yeah.
which would add in more merit to the presentation, I feel.
Yes. Shrikant sir?
Yeah, I told no. They should have
Any
presented
other,
more.
anything else?
That's
Okay.
all.
Yeah, Praveen, that is what. So your preparation, what I felt was like it was undercooked and you're probably not ready. Like as usual, you're not there. Like in your earlier
You should
presentations.
have presented this to the registrar before presenting here and should have taken this thing input.
Although there were some diagrams and all those things, you never explained in detail or you never went into the depth. You're like superficially, you just mentioned skin, muscle, and all.
Preoperative investigations, Doppler, angiography, all those things you never talked.
Yeah, so it was like an undercooked presentation, as well as the contents could have been more better, as well as the details where you went into were not adequate. That is what I
Nowadays,
felt.
amputation is not done without angiography.
Without?
Angiographies.
Nothing of that sort, I think so. Sir, is angiogram mandatory before you do amputation?
Or Doppler.
Sir,
Answer?
I simply go by the palpable pulse only, sir, because sometimes Doppler wise they'll give you good velocities, but that is not enough sometimes. So
That is what. So if the limb is
there
not
was
salvageable,
in fact, there was a very big study, sir, from vascular department, where which is the most ideal method to find out whether a stump will heal or not, and they compared palpable pulse, Doppler velocities, CT or MRI imaging, digital subtraction in the cath lab, then PVR, segmental pressures, and then transcutaneous oxygen pressures. And then all these things, the final decision was palpable pulse above the stump is the best compared to all the other methods.
yeah. Okay, sir. I think anything else? Otherwise, we will conclude. Praveen, lots are to be improved, and I think
Yes.
homework, whatever the questions were asked.
Yes, sir.
Thank you, sir. Thank you, Shravan, sir. I
Thank you,
think
sir.
we look forward to seeing you coming into our classes more and more.
Sure, sir. It will
And
be my pleasure,
thank
sir.
you,
Thank you
Shrikant,
for the
sir.
invite.
Yeah. Thank you, Shrikant, sir. Thank
Thank
you.
you,
We'll
Shrikant, sir.
conclude then.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you, Praveen.
Yes, sir. Thank you, sir.